Good morning, one and all. So we have been seeing several interesting cases here. So I thank the organizers for this opportunity. I would like to share a different scenario here, a distal femur fracture with multiligament status. So I am at Preeti Hospital, Madurai. So this is the fracture, a 32-year-old gentleman who presented with road traffic accident, and he had a comminuted distal femur fracture with this type of configuration, C3-3 type, and opposite side he had an PCL avulsion injury, and we picked most of these injuries and tried to address them. So this fracture was very well fixed, and good articular reconstruction was done, and the PCL was also fixed. And we started an aggressive rehab protocol, and this patient down the lane 6 months was able to get reasonable range of movement, and we did a bone grafting also for him. And down the lane, like 6 to 8 months, once he regained his motions, he started having instability. So he complained of instability, and this was his instability pattern, where you can see the tibial sag was there. He had an anteroposterior draws positive, grade 3, and also he had an varus instability both at 0 and 30 degrees of range of movement. So here is the ARS. So I think so it was a very pretty simple. So we have to rely on all these parameters. We need to take a stress X-ray here. We need to rely on our clinical examination. MRI is little challenging here because of so much of implant here. So what challenges we have now? So the patient is having gross instability. So we are not sure whether the fracture has united everything. So should we retain or remove the implant, and how to proceed? What are the graft options, and where do you try to place your tunnels in this gentleman? So this is a very good paper by Laprade group, where they have shown that the stress X-ray can confirm the diagnosis in these kind of injuries. So we are all aware. So the stress X-rays gives us good information when we are not able to do an MRI. So the amount of opening or the translation can give us that there is a significant ligament instability, and scanogram also gives us, helps us to plan what to do next. So the second ARS. So I think so majority of us are in opinion that we will do a partial metal exit and do a ligament reconstruction procedure. So I was also thinking on the same page. So these are the tunnels. This is the space what we need to do our ligament reconstruction. So I plan to do a partial metal exit for him. I was not sure about the fracture healing because it was almost 8 to 10 months now, so just did not want to remove the entire implant. So we did a removal of the medial plate, and we did a removal of all the lateral screws which would hinder our tunnels, and just replaced with the smaller anterior screws. And then I choose to use both the hamstrings, and used a quadruple semi-T for ACL, which was 9 mm, and 3-strand semi-T and gracilis for PCL, for which was about 10 mm, and gracilis with fiber tape for PLC. At that time, I was not very confident of peroneus, and also this patient had some kind of dysvascular limb, so I was hesitant to take peroneus graft at that time. So this was the arthroscopic picture. So we can see that the ACL, few fibers were there of both ACL and PCL, but they were all lax. So I retained them just for whatever proprioception or usefulness they have, and then created a posteromedial portal here. So we did a preparation for all the PCL tunnels here, and I usually do femoral tunnels first and then do the PCL. So I did my femoral ACL anatomical tunnel, and then we did a PCL tunnel for femoral. So this is the advantage of having the footprint at the end, retaining the footprint, so we can go at the footprint and try to create tunnels there, so that so this was the femoral PCL tunnel, and then did a PCL tibial tunnel at the champagne head, and this is the ACL tunnel. So on the graphs were railroad, and here we are all aware about the killer turn. So now there are so many techniques which have been developed to avoid these kind of issues. 2 years ago, we all were using the switching stick or the Wissenger rod to guide the graft into the tunnels. So I did the same technique here. I use suspensory fixation for the both the sides, and this is the nice robust PCL graft which is coming, and this is the ACL graft which has come in, and then you can see that they were good. So I did a Larsen here for him, and also augmented with a fiber tape. So this was the post-op X-ray, both the tunnels, and this is at 18 months follow-up. And this is, he's a shopkeeper, and he's going back to his job, and he's doing this, he has a good stability, and he's able to do all his daily routine activities. So the physio, we all know, is very important in these kind of injuries, because already his quadriceps and all has been affected because of the fracture per se, and getting the rehab is very important. So this is a literature review where we all know that there are a significant amount of ligament injuries whenever we have fractures around the knee. So we have our own paper published in floating knee in Injury Journal, where we have come up with a classification for floating knee injuries, where we stressed the importance of these osteoligamentous disruption. We called it as a modifier 2. So identifying these injuries will always help. This is one retrospective analysis we are doing, where we analyzed 595 cases of fractures around the knee joint, and we saw that there were 92 patients who had an avulsion injuries, and this was the fracture pattern we had. The femur fractures had 24 patients with instability. It is most of the time the proximal tibia which are associated with these ligament injuries. So if we try to identify them, we will be able to give a gratifying. This is the various types of Schasger fracture with the different type of instability pattern here. And since we are able to identify them early, and we are able to give a gratifying results for these complex injuries, we have noticed that 13.5% of femur fracture had instability, and around 20% of tibia fractures have instability. So I have these few other examples. So we did this. So this is what I was telling in the morning case. This is we did a bicruciate repair in this gentleman, along with the avulsion of the tibiofibular fracture. So this paper, we published it in JAJS. So the take-home message here is, so the high index of suspicion for knee instability in fractures around knee, 1 out of 5 to 6 femur or tibia fracture will have instability. We have to look for the telltale signs, at least for the avulsion fractures, which can be easily picked up. And CT is very useful, MRI in selected cases. Evaluation under anesthesia after fracture fixation has been a very important learning point for us. So we are able to grasp most of these instabilities on day one. Thank you.
Thank you, Dr. Prahalad. The house is open for the question.
Is it a protocol to take an MRI in all these proximal tibia and distal femur fractures? Taking an MRI in the index period.
So that's what I mentioned, that CT is more useful. MRI, we do it in a very selected cases. I think so when we have this kind of fracture pattern, I don't think so that even we'll be able to get much information on the MRI on day one. But there are certain fractures we saw in the morning, those rim avulsion fractures or these kind of fractures will definitely MRI will be useful, but not in type 2 Schasger, type 3 Schasger, where we know that sometimes it may not give much information.
Prahalad, very nicely fixed.
Yeah.
Can you give us some tips on how to make the tunnels? Do you think the use of retrograde reaming devices will give you an edge rather than the conventional reamers and reconstructions?
Yeah. So I did this case 2 years ago. So I was very comfortable doing this. So that was the plan in my mind. So I removed all the posterior screws. I knew where my tunnels are going to come. So I made sure that I would avoid the plate and the screws and get the tunnels from inside out. Definitely you can always think of retrograde drilling technique, because now we have got good devices and all, so that's a good option as well.
Prahalad, Prahalad here.
Yeah.
Nice case. What you were trying to show in the scanogram, there was some malalignment as well, or it was absolutely normal? The scanogram
so it was symmetrical both the sides.
Okay.
So I don't think so it was any major thing. The gentleman was around 35 years old, so it was almost same on both the sides.
It was not a varus malalignment?
No. Yeah.
So Prahalad, definitely once the fracture is fixed, we should re-evaluate clinically to see if there is any ligamentous instability. So do you have any experience of doing single stage, such kind of trauma with ligament fixation or repair, reconstruction in one stage?
Yeah. So now, actually last week also one of my orthopedic surgeon's uncle had sustained a distal femur fracture. So I fixed his ACL. I just took a couple of bites and just brought it, pull out and just repaired that ACL. So now whenever we get an opportunity, we have done several such cases. We have taken pull out sutures if the ACL is intact, because we are able to see everything. So that is an option, but I don't do reconstruction on day one. But wherever possible, repair I try to do.
So anyone in the house having any experience, medico-legal experience of delayed judgment to diagnose your ligamentous injuries? Because often patient complains they were never informed that there is a ligamentous instability at the primary surgery. So any experience on that?
No, I think so. That's the reason I gave the message that 1 out of every 6 fractures around the knee is going to have instability. So we have to give this thing to the people.
Mukesh.
Prahalad, with that 3 ligaments going with primary fracture on table after fixation, it would have been quite obvious that the knee is so unstable. So we usually take the knee through full range of motion after fracture fixation. Have you realized that instability on day 1 after fracture fixation?
On day 1, when we had a fracture fixed, I don't think so. Yeah. So as I told you, as our protocol, we do a fracture evaluation. So at that time, I don't think so.
After you fixed the fracture on table, after you closed and before you came out from the theater, we take the knee through range of movement. Yeah. At that time, with that unstable knee, didn't you realize that there was sag and everything opening?
No.
Achha. So if we would have realized that, we would have given a PTS brace at least for 6 weeks and delayed the rehab, so that we would have at least have PCL and PLC healed and would have dealt with ACL later.
And this patient had a bilateral injury. He had a PCL injury opposite side. So obviously he was little slow on rehab as well. So we were not very aggressive in the initial first 4 weeks. So he was protected as well.
Okay.
So Rahul, are you?
Can you please show us the post-op X-ray after the reconstruction?
I think so. The presentation is gone. The next presentation is there.
Because I think the rigid loop was not sitting on the
There was little off on that this thing, but I had
there was no laxity after that.
Yeah, no laxity. Yeah.
Okay, thank you, Prahalad.
Thank you.
Dr. Pankaj.